The wrist joint, which is also known as the radiocarpal joint, is an articulation between the radius and the carpal bones of the hand. The carpal tunnel is a narrow passageway found on the anterior portion of the wrist. In this video, we are going to demystify and unravel every mystery in the wrist joint and the carpal tunnel. Don't forget to like and subscribe. Like we stated, the wrist joint is an articulation between the radius and the carpal bones of the hand. It is a condyloid-type synovial joint, which marks the area of transition between the forearm and the hand. Let's have a look at the anatomical structures of this joint. Just like every other joint we have discussed so far, the wrist joint has articulating surfaces, joint capsule, and stabilizing ligaments. The wrist joint is formed by an articulation between the distal end of the radius and the articular disc, and also the proximal row of the carpal bones, with the exclusion of the pisiform. Together, the carpal bones form a convex surface which fits into the concave shape of the radius and articular disc. The ulna is prevented from articulating with the carpal bones by the presence of the articular disc. Instead of articulating with the carpal bones, the ulna articulates with the radius just proximal to the wrist. This articulation is known as the distal radio-ulnar joint. The joint capsule of the wrist joint attaches to the radius ulna and the proximal row of the carpal bones. It is lined internally by a synovial membrane, which produces synovial fluid to reduce friction between the articulating surfaces. The ligaments responsible for the stability of the joint are four altogether. We have the palmar radiocarpal ligament, dorsal radiocarpal ligament, ulnar collateral ligament, and the radial collateral ligament. The palmar radiocarpal ligament is located on the palmar side of the joint, that is the anterior side of the joint. It passes from the radius to both rows of carpal bones. Its function, apart from increasing stability, is to make sure that the hand follows the forearm during supination. The dorsal radiocarpal ligament is found on the dorsum, posterior, side of the hand. It passes from the radius to both rows of carpal bones. It contributes to the stability of the wrist, but also ensures that the hand follows the forearm during pronation. The ulnar collateral ligament runs from the ulnar styloid process to the trichotrum and pisiform bone. It acts to prevent excessive radial deviation of the hand. The radial collateral ligament runs from the radial styloid process to the scaphoid and trapezium. It acts to prevent excessive ulnar deviation of the hand. Let's look at some movements associated with this joint. It is important we note that the wrist is an ellipsoidal condyloid-type synovial joint, allowing for movement along two axes. This means that flexion, extension, adduction, and abduction can all occur at the wrist joint. All the movements of the wrist are performed by the muscles of the forearm. The flexion movement is produced mainly by the flexor carpi ulnaris, flexor carpi radialis, with assistance from the flexor digitorum superficialis. The extension movement is produced mainly by the extensor carpi radialis longus and brevis and the extensor carpi ulnaris, with assistance from the extensor digitorum. The adduction movement is produced by the extensor carpi ulnaris and flexor carpi ulnaris. The abduction movement is produced by the abductor pollicis longus, flexor carpi radialis, extensor carpi radialis longus, and brevis. Let's look at some of the stabilizing factors and also some of the structures that aid in the mobility of the joint. The wrist joint is a highly mobile joint that allows the hand to move in several directions. Because of this, the wrist joint can easily be injured. The wrist joint does maintain some stability due to intrinsic and extrinsic ligaments. Intrinsic carpal ligaments are the tiny ligaments between the carpal bones. They are short ligaments that provide stability but are easily damaged with excessive force or twisting because of their small size. The extrinsic ligaments, which include the palmar radiocarpal ligament, the radial and ulnar collateral ligaments, are stronger, and they stabilize from the radius and ulna to the carpal bones of the wrist. Having understood the wrist joint, let us cruise through an interesting passage found in this joint called the carpal tunnel. It is a narrow passageway found on the anterior portion of the wrist. It serves as an entrance route to several tendons and the median nerve into the palm. Let's look at its borders. The carpal tunnel is formed by two layers, a deep carpal arch and a superficial flexor retinaculum. The deep carpal arch forms a concave surface which is converted into a tunnel by the overlying transverse carpal ligament, which is also called flexor retinaculum. The deep carpal arch is concave on the palmar side, forming the base and sides of the carpal tunnel. It is formed laterally by the scaphoid and trapezium tubercles, and medially by the hook of the hamate and the pisiform. The superficial flexor retinaculum is a thick connective tissue that forms the roof of the carpal tunnel. It turns the carpal arch into the carpal tunnel by bridging the space between the medial and lateral parts of the arch. The flexor retinaculum spans between the hook of hamate and pisiform, that is medially, to the scaphoid and trapezium, that is laterally. Let's look at the contents of this tunnel. The carpal tunnel contains a total of 9 tendons surrounded by synovial sheaths and the median nerve. The palmar cutaneous branch of the median nerve is given off before the nerve gets to the carpal tunnel. This branch of median nerve passes superficially to the flexor retinaculum. The tendons that pass through the carpal tunnel are the tendon of flexor pollicis longus, 4 tendons of flexor digitorum profundus, and the 4 tendons of flexor digitorum superficialis. The 8 tendons of the flexor digitorum profundus and flexor digitorum superficialis are surrounded by a single synovial sheath. The tendon of flexor pollicis longus is surrounded by its own synovial sheath. These sheaths allow free movement of the tendons. Sometimes you may hear that the carpal tunnel contains another tendon, the flexor carpi radialis tendon, but this is located within the flexor retinaculum and not within the carpal tunnel itself. Once the median nerve passes through the carpal tunnel, it divides into 2 branches, which are the recurrent branch and palmar digital nerves. The palmar digital nerves give sensory innervation to the palmar skin and dorsal nail beds of the lateral 3.5 digits. They also provide motor innervation to the lateral 2 lumbricals. The recurrent branch supplies the thenar muscle group. Let's have a look at the clinical relevance of the wrist joint as well as the carpal tunnel. The clinical relevance peculiar to the wrist joint is scaphoid fracture, anterior dislocation of the lunate, and Colles fracture. In the fracture of the scaphoid bone, the characteristic clinical feature is pain and tenderness in the anatomical snuff box. The scaphoid bone of the hand is the most commonly fractured carpal bone, most especially by falling on an outstretched hand, which can be remembered with fouche. The scaphoid is at particular risk of avascular necrosis after fracture. This means that a fracture to the middle of the scaphoid or wrist may interrupt the blood supply to the proximal part of the scaphoid bone, rendering it avascular. Patients with a missed scaphoid fracture are likely to develop osteoarthritis of the wrist in later life. Anterior dislocation of the lunate can occur by falling on a dorsiflexed wrist. The lunate is forced anteriorly and compresses the carpal tunnel, causing the symptoms of carpal tunnel syndrome, which we will look at shortly. This manifests clinically as paresthesia in the sensory distribution of the median nerve and weakness of thenar muscles. The lunate can also undergo a vascular necrosis, so immediate clinical attention to the fracture is needed. The Colles fracture is the most common fracture involving the wrist, caused by falling onto an outstretched hand. The radius fractures, with the distal fragment being displaced posteriorly. The ulnar styloid process can also be damaged and is avulsed in most cases. This clinical condition produces what is known as the dinner fork deformity. Let's look at the carpal tunnel syndrome, which is the clinical condition associated with carpal tunnel. The compression of the median nerve within the carpal tunnel can cause carpal tunnel syndrome. It is the most common mononeuropathy and can be caused by thickened ligaments and tendon sheaths. Sometimes etiology is, however, most often idiopathic. If left untreated, carpal tunnel syndrome can cause weakness and atrophy of the thenar muscles. Clinical features of this condition include numbness, tingling, and pain in the distribution of the median nerve. The pain will usually radiate to the forearm. Symptoms are often associated with waking the patient from their sleep and being worse in the mornings. Tests for carpal tunnel syndrome can be performed during physical examination. The test includes tapping the nerve in the carpal tunnel to bring about pain in median nerve distribution. It is called Tinel's sign. The next test is holding the wrist in flexion for 60 seconds to elicit numbness or pain in median nerve distribution. It is called Phelan's maneuver. Treatment of this condition involves the use of a splint and holding the wrist in dorsiflexion overnight to relieve symptoms. If this is unsuccessful, corticosteroid injections into the carpal tunnel can be used. In severe cases, surgical decompression of the carpal tunnel may be required. Don't forget to subscribe to Joan Academy. See you in the next video.